Another thing everybody's dying to know about is the GLP-1 agonists. What are GLP-1 agonists? What is semaglutide? What is Wegovy? What is Mounjaro? So if you could just start with a basic education to the audience with all those fancy words I just used.
Sure.
What are these things? What's the difference between them? What do they do, and who are they good for?
Sure. Great question. This is a big topic now. Everyone's very interested in this class of medications. They're called GLP agonists. Traditionally, they were actually developed to manage diabetes with their blood sugar balancing activity. Actually, ironically, they originally found this medication as a derivative of a substance that was found in lizards, actually.
Really?
Yeah,
lizards?
Lizards. Yeah, so there was a lizard that, I forgot the name, I'll be honest with you, that was found to feast once a year and live without eating for an entire year, or 6 months or to 12 months. And they wanted to study why this lizard was able to live without eating. And what they found was there was an incredible amount of GLP in this lizard. And they wanted to realize, why was this GLP in this lizard allowing it to not eat but still survive? And they thought maybe this could be a therapeutic kind of treatment in humans. And as it turns out, this GLP peptide can actually serve to reduce appetite and manage blood sugar levels, and also allow you to survive without eating for prolonged periods of time. So ultimately, it became a modality for treating diabetes in humans. There's a few early generation GLPs, like liraglutide, and those that have kind of expired. And there's two GLP agonists now that are predominant in kind of the medical world now, and it's semaglutide and Tirzepatide.
And so these are the two up-to-date new GLP agonists.
That's correct.
Okay.
And so semaglutide is the peptide that's found in what people traditionally know as Ozempic. And now there's one called Wegovy, which is for obesity.
Yeah.
Then you have Tirzepatide, which is not only a GLP agonist, it's also a GIP agonist. So it's a dual peptide agonist. And it's the peptide that's found in Zepbound, which is an obesity medication, and also Mounjaro, as many people know for diabetes. So these medications are very multifaceted. Although they were originally used for diabetic patients, they have served to help patients lose weight and manage their obesity, and they're very effective at that. And I think their benefits to risk ratio are largely very favorable for people.
Really?
Which means that they're very effective at helping people lose weight. And the risks are largely, symptomatic, so to speak. So we haven't seen much evidence that this is detrimental to people's health, unless rare circumstances. There's rare circumstances that people do have dangerous, reactions to medications. It's like that for every medication on the market. So that's not the status quo.
Okay, so GLP-1 agonists, they're regulating blood sugar.
That's right.
They're reducing the hunger feeling, so you can go longer without eating. Is that right?
That's right.
Okay, and no major side effects. Now, the problem that I've heard is that once you get started on these things, once you are discontinued off these medications, you have a rebound increase in the weight that you've lost. So what do you say about these medications getting dependent on them to maintain or to lose the weight and then maintain your weight, and the risks of gaining it all back when you discontinue these GLP-1 agonists?
That's a great point, and everyone worries about that. They come to my office, they're like, oh man, if I want to get on this medication, am I going to gain weight right away? It's not necessarily true. It really depends on the case. So just like I said earlier, every treatment should be tailored for a person. So there's definitely cases that you get on this medication, you lose a ton of weight really fast, and you come off the medication and you do gain a lot of weight. But there are situations where you get on it and you slowly taper off the medication and your weight is a lot lower than where you started. And that's the goal that we have. And that's why it's important to consult with your physician before starting these medications, to create a plan of action, basically.
So your own personal experience, anecdotal experience, how much success do you have starting a patient on one of these GLP-1 agonists, having them lose their weight to get to whatever their goal is, slowly tapering them off, and having them maintain that goal weight after they've been fully discontinued off the medication? Your own personal experience with your patients. How is it going?
I will say off the bat, if you are a long life, how do you say this? If you are lifelong like person who's been obese their whole life, even from child to teenage years, your parents are obese, your grandparents are obese, that is very difficult for your body to overcome. And in those cases, I think coming off the medication is probably not the right decision. I actually would keep those patients on the medication. And evidence shows that keeping them on the medication is recommended, and you shouldn't take them off because the higher chances that they're going to gain all their weight back. That being said, there are people who are not lifelong obese patients or overweight patients, and throughout their life, throughout the years, they've gained weight, and they want to lose weight, and they want to use these GLP medications as a tool, and that's very effective, and it can work for people. And I see a lot of patients like that, and I put them on the GLP medication for about 6 months, maybe more, and sometimes they want to come off the medication, and we slowly taper them off, and we are very on top of their lifestyle and how they've modified their lifestyle since they've been on the medication, and that helps them sustain their weight loss.
Yes,
I would say statistically, at least 50% of my patients that have tapered off thus far have been successful in maintaining their weight off.
Wow, that's amazing.
However, there's higher likelihood of success of coming off the medication if you've been on the medication longer. So if you've only took the medication for a short amount of time and you quickly come off of it, there's a higher chance that you're going to rebound that weight.
That's fascinating.
Yeah.
What I've seen is patients that are started on medications like this, where it reduces their hunger, it allows them to then work to build healthy habits as far as diet and exercise. Yeah. And the longer they're able to maintain these healthier behaviors, the more they can get, formed into habits, and the more success they have of maintaining these habits once the medication has been discontinued.
That's right.
Now, a question for you. What is the indication for starting this medication? Meaning, what do you need to see in someone where it's medically appropriate to start the medication, and I suppose also medically appropriate for the insurance to pay for it? So what are the indications? Who shows up, and what do you need to see in them for them to be started on this medication?
That's a good question. You mentioned insurance companies, so that's interesting because the qualifications for insurance companies are actually separate from what the actual manufacturer is.
Interesting.
And that creates a problem, which I'll talk about later. So generally speaking, this medication is started for patients who are in the obesity category, which means their BMI is above 30. Which for most people, it's appropriate to say that their BMI above 30 is obese, but not in all cases, because some people may not be obese and their BMI is above 30, and you have to be careful.
Of course, a lot of muscle mass.
A lot of muscle mass. Yeah, exactly.
Heavy weight, short stature,
Exactly. Or if your BMI is above 27 and you have multiple comorbidities, such as high cholesterol, prediabetes, fatty liver, or some other medical condition that's increasing your overall health risk, you may be considered to benefit from these medications. However, we usually don't recommend starting these medications right off the bat unless you've tried weight loss from other measures, non-medication measures, whether it's diet changes, calorie restriction, exercising, at least for 6 months to a year, and you've been unsuccessful, then we're like, okay, let's try some medication to bring your weight down and improve your health. That's the candidate that we look for, basically. So I really like using the medication because I see how much it improves people's health, how much it improves their lives, and I love practicing that kind of medicine. And I think it's a great thing that's come out in the medical world.
How often do you see people abusing it? Now, here's where our worlds might collide as patients that have body dysmorphia, anorexia, bulimia, disordered eating. How often in your practice, mind you, the man's in Beverly Hills, this is LA, this is Hollywood.
It's true.
There's a lot of people that have trouble with body image and they have disordered eating. How often do you see somebody come to you seeking these medications to utilize them in like a pathological, self-destructive, unhealthy way? How often are you seeing that?
All the time.
First of all, how often do you see that? Second of all, how do you approach the conversation with the patient as to why you won't prescribe it and what's going on with them?
That's a great question. I think it depends on the case. To answer your question, I see it all the time, all the time, multiple times a week. I see young females.
Multiple times a week.
Yeah, multiple times a week. There may be normal weight or in some cases even underweight, and they want to get on the GLP weight loss medications. I refuse to give the medication to them because I think it's not safe for them. However, there are some situations where people are in the normal weight range, but they're approaching overweight and they're really struggling to lose weight, especially if they're menopausal or premenopausal, and they're really struggling to keep their weight in check despite calorie restriction and those kind of things. I do sometimes help patients with the weight loss medications. I do help them. But usually if they're not meeting the criteria, I have to tell them, I think this medication is not the right fit for you. And I think it's not safe for you to be on this medication, given that your weight is not overweight and you're underweight. So I don't consider them as good candidates for that. Yeah. But I see it all the time. There's a lot of vain reasons why people want to lose weight, and they come to me to help them with that. And
what are some common side effects of these GLP-1 agonists?
The most common side effects are largely gastrointestinal, especially when you first start the medication or the first few days of injecting the medication. You may get nausea, you may get acid reflux, stomach upset. Some people complain of bloating, constipation, and in some cases diarrhea on the higher doses especially. Also some miscellaneous side effects like fatigue, headache, body aches do occur with some patients. It's generally considered that the second class of medication, Tirzepatide, generally has a little bit.
That's your Mounjaros.
That's the Mounjaros have a little less side effects, although anecdotally it's not always the case. And Semaglutide has a little bit more gastrointestinal side effects, but also the Tirzepatide is also considered to be more effective than Semaglutide. So
interesting.
That's another thing.
So if, let's say your cousin was coming to you and they were obese.
Yeah.
The Tirzepatide versus the Semaglutide. The Tirzepatide, your Zepbound, your Mounjaro, is that a better medication than the Wegovys, aka the Semaglutide?
It's a great question. I don't want to put down any Wegovy or Semaglutide people out there, companies out there, because I think it's a great medication. If you're morbidly obese or you're very obese, I actually, ironically, paradoxically, would recommend starting them on the Semaglutide, which is considered the less potent of the two. And the reason for that is I want to max them out on the Semaglutide before I give them the higher one. Because if you put them already on the Tirzepatide, the higher version of the medication, you have not many places to go after that. So I want to maximize the Semaglutide on the patient. And if they get to a point where they plateau on their weight loss, then I'll switch them to the Tirzepatide.
Fascinating.
I've learned that is the most effective treatment for very obese patients. Yeah, and they do very well in the long run. So to answer your question, I would say the Tirzepatide medication is better for the long run for patients' weight loss management. Yeah.
Okay, so on the topic of Semaglutide, actually, there was a paper released in JAMA recently talking about the effect of Semaglutide with reducing alcohol consumption or alcohol cravings in patients that have alcohol use disorder. So for the audience out there, the paper is titled Once Weekly Semaglutide in Adults with Alcohol Use Disorder, a randomized clinical trial. So let me read some of the main points from this, and let's hear what you have to say. So some of the key findings from the study, that the participants in the study reduced alcohol consumption, reduced drinking intensity, not frequency. So the times that they had alcohol, they drank less of it, and they craved alcohol less. Interestingly, in the study, they also found that some participants who smoked cigarettes, they had less cravings and actually less reduction in, or more of a reduction in cigarette use per day, so less smoking of cigarettes. So what this study shows that there is absolutely a place here to further investigate semaglutide for alcohol use disorder and potentially cigarette addiction. Brand new study. So this medication, it seems like a wonderful medication. We talked about the symptoms as far as potential side effects. Now there's other scarier side effects out there that are very rare. If you guys are curious, leave questions in the comments. We can get to that. But the study today shows that there's absolutely potential for this semaglutide to have even more utilizations, meaning in getting off cigarettes and also getting off alcohol. Fascinating development literally this month.
I'm so glad you brought this up because, like I was saying earlier, I do love using these medications for my patients because they have so many benefits outside of just weight loss. And I've seen in most of my patients, their alcohol consumption has come down dramatically after using
Fascinating.
these medications.
You've seen that in your own practice.
Absolutely.
Alcohol consumption reduction.
Substantial.
On semaglutide.
Instantly.
Really?
Instantly, they lose the interest of drinking. And some cases just cut down dramatically where they're not excessively drinking, but they can drink at the level that they feel good.
Fascinating.
Yeah.
So this study came out and it confirms your own anecdotal experience with your patients drinking less alcohol when on this medication.
That's right.
Amazing.
And more so, it's showing even more benefits that we're starting to realize, including improved menopausal symptoms in women who have hot flashes. I've learned this in my practice indirectly, and recent studies have proven that women with menopausal symptoms actually improve on the semaglutide and tirzepatide. They smoke cigarettes less. And generally speaking, if you want to put like an umbrella around these medications, I would say that they reduce the desire for cheap dopamine. Cheap dopamine. The unfortunate collateral from that is that this can sometimes reduce someone's sex drive, which in some cases could be a negative side effect, and people can have reduced sex drive, and that can impact their relationship, their marriage, and their overall kind of like sex life. That's the negative side of that, but the positive side is you partake in less kind of destructive behaviors such as drugs, alcohol, smoking, risky sexual behavior, but also think about how it may affect someone's relationship if you reduce it too much.
Interesting. So you ask about someone's sex drive and libido when you start them on this medication because a reduction in libido, aka sex drive, is a potential side effect of these GLP agonists?
Fortunately, I don't see it that much in my patients, and most of my patients don't complain about it. But the literature shows there is a decent amount of evidence that shows that it can lower libido in some patients. Not many of my patients have complained about this as like a side effect and a reason for them to stop the medication. But if you're a provider or a physician who is prescribing this, you should be mindful of that prior to starting the medication so that if a patient already has hypoarousal disorder, a low sex drive, this medication might even further lower that. So I don't necessarily ask them, but I may advise them that this might be a potential side effect.
Fascinating. Let me ask you another question. So a lot of patients come to me, they say that their sex drive is low. So I know how I approach that from a psychiatric perspective, but are there any agents or medicines out there that help boost someone's libido? Let's say their testosterone is fine. Let's say they're sleeping fine. Their complaint is low sex drive. Is there anything out there that helps boost libido right now?
Absolutely there is. It depends on whether you're male or female. It goes without saying, the first thing to think about is a patient's lifestyle, right? You got to look at their lifestyle, you know. What's their relationship like? Are they having relationship issues?
Of course.
You know, the stress between partners can be the primary drive in your sex drive issues. That's the first place you got to look. And a lot of people forget about the key glaring, issue there.
Yeah, of course.
After you've ruled that out, you have to look if there's actually any other chemical reasons for that, whether hormonal reasons. Do you have any deficiencies in thyroid hormone or testosterone, estrogen, anything that could be medically causing them to have low libido? The overwhelming majority of the time, if they're young and healthy people, their low libido is having to do with their psychological status, what's going on in their life, their stress, poor sleep, poor lifestyle. That's probably the main thing, or even relationship issues. But regardless, you can still address those problems with different treatments, like you're asking me. For men, even the taking of a daily PDE agonist, such as like Cialis or Viagra, just the daily intake of that could improve their testosterone. Even
Their
the daily
libido.
intake of like a Cialis or a Viagra could improve your sex drive as a male.
Yeah. It's a fascinating point because I don't think a lot of doctors know this, but these Cialises, these Viagras that are mostly a plumbing issue, they open up the vasculature and the vessels to allow someone to get and sustain an erection easier when they're sexually aroused. There is actually a bit of central action with these medications, central meaning like in your brain, to increase sex drive and libido. It's minimal, but a lot of providers don't realize that these things actually do have a bit of central action. Let me ask you another question. A lot of patients ask me this, men and women. I know my answer, but hey doc, what does a normal sex drive actually look like? How should my libido, what is a normal male or female libido? Like, what am I comparing this to? So what is your answer to what is a normal sex drive for a man and or a woman?
That's a tough question because it's so individualized. It could be different per person. So I would say the answer is if it's less than where you want it to be and it's much lower than where you want it to be, within reason. You know, if you're someone who's used to masturbating 3-4 times a day and now you're masturbating 1 or 2 times a day, is that really a reduced libido? It's hard to say. It sounds like you're okay, you know? But if you're saying that you normally, have a sex drive every day and you want sex every day, and all of a sudden you don't want it for months, that's clearly a low libido. And the question is, how much is it affecting your life? That's the most important thing. Is it reducing your relationship satisfaction? Is it reducing your quality of life, your health? Then we really need to discuss what are some treatments for that. The interesting thing is there are some peptides that are out on the market now that are FDA approved for improving sex drive that a lot of people don't actually know about. There's a medication called PT141.
PT141.
PT141, which is a peptide that's FDA approved for females for low libido, especially women who are menopausal. And what it does is it basically stimulates the melanocortin center of the brain, which indirectly improves the libido of a patient.
Fascinating. In females?
Females is what it's approved for, FDA approved for, but it actually works in both genders. Male and female. And actually, I predominantly use it in my male patients because they want something to boost their They want something that can boost their sex drive without taking testosterone or Viagra or Cialis, and it's really effective.
Now, is that an injection? Is it a pill? How often do you have to take it? How long does it work for? PT141.
So PT141 is recommended to take up to 2 times a week. You don't want to take it more than that. It has the side effect of actually causing bronzing of your skin or tanning of your skin because it's triggering your melanocyte center.
Is it an injection, a pill? What is it?
It's a injection, subcutaneous injection. So it could be your lower abdomen or thigh, just like how you would take the weight loss medications like GLPs. It could cause the side effect of flushing for some patients, but it works instantly. It can work in 1 hour after using, and it helps with erectile dysfunction. It helps with desire. However, only lasts 2 to 3 days. So you should use it, up to twice a week to help promote sex drive. And most people use it as needed. They're not using it regularly. They're using it to help boost their sex drive, when needed.
But I suppose there's some planning involved because they have to come to your office and actually get an injection. So it's not like they can just inject themselves, Friday afternoon before they start their weekend. They need to make an appointment with your office. Unless, am I wrong? Is it a take-home syringe or do you have to go to the clinic to get it?
Most of my patients take it home.
Oh, they do take it at home.
So they're able to use it when they need it.
So you have to give them an education on how to shoot themselves with the medication?
Exactly, and it's very easy to do so. Once we figure it out, you could do it on the go. You could do it anywhere. Yeah.
Now, do you have any here for me to take home as a sample?
Not today, but next episode.
And if I squirt this into my wife's coffee, will it still work that way?
I think you're going to have a great weekend with that.
Okay, now on that note, Viagra, Cialis, your PDEs, as you called them, do these work in women, or is it just men because of, getting them to like get and sustain an erection? Can women benefit from taking Cialis or Viagra?
It's generally considered that we don't give these to females. It's not targeted for females. It doesn't work the way it does on females because the main premise is to improve erections. You're basically improving blood flow to the groin of males to improve their erections. So I wouldn't advise females taking it.
Now, I have heard the opposite, and I actually do sometimes prescribe females.
Oh, yeah?
Because I believe it also increases like clitoral engorgement, making the clitoris more sensitive and more easily aroused during sex. So I personally will prescribe these in females.
Interesting. Very
Very infrequently. How many times have I done that? Probably less than 10. And how often has it been effective? Maybe half the time. But some psychiatrists will prescribe these for females.
Oh, really?
Off-label, being that they're only indicated for male patients.
Interesting.
Yeah.
I got to read the literature on that. I maybe don't know that, but I'll look into that. Maybe it is something that's useful for females. It's just generally not indicated in females. It might, because it's not a hormonal-based medication, you might be right. Maybe it is improving blood flow for women too, and that might improve their libido as well.
Yeah.
I haven't looked into it that much.
Yeah. Now, I don't think there's literature. I think it's off-label.
Off-label,
Again,
yeah.
even if it's off-label, I don't know if there's a robust literature out there for it. And I've done it so infrequently over the duration of my practice, maybe up to 10 times. So something to look into. And if there's any women watching that are interested in that and want more information, leave a comment. We'll get to that. Happy to provide sources.
It's a good idea. It's a good question. I'll look into that. I think it's definitely an area to look into.
Yeah.